Hi and hello everyone. This is your Dr. Bharath Kumar V D, Pharma faculty, and in this session I'll be having Pharma and Psychiatry test and discussion. So let us start with the Pharma T&D first. Let us start with the question. Now, before I proceed to this, so please understand, if you believe in yourself, anything is possible. So the most important thing in any exam preparation is trust your preparation. So I hope the audio video is fine. Let me check from my end. Okay, so I got a message that everything is fine. Then we can proceed. Okay, so everything is fine now. I hope you have attended the test in the morning. And let us start. The first question reads like this. 26-year-old young lady attends medical emergency and is labeled acute severe asthma, also called as status asthmaticus, by the emergency physician. Which one of the following is not a bronchodilator? Now the question what I am asking you is, which of the following drug is not a bronchodilator? And remember, in emergency, we use bronchodilators. So first option, ipratropium bromide is a bronchodilator. We call it as SAMA. SAMA means short-acting muscarinic antagonist. LAMA drug is tiotropium bromide. Theophylline is also a bronchodilator. We call it as methyl xanthines. Methyl xanthines. Formoterol, salmeterol, they are called as LABA drugs. LABA stands for long-acting beta-2 agonist. So all the three A, B, C are bronchodilators. So all these can be used in attack of asthma. Then what about option C? Sodium chromoglycate. It is a mast cell stabilizer. And the mast cell stabilizers are used for prophylaxis of asthma. So sodium chromoglycate is used in prophylaxis of bronchial asthma. So the answer for this question is option D. Option D. Now moving on to some concept what we need to understand. Which drugs are used as controllers or prophylaxis in asthma? First one is montelukast. What is the mechanism that is frequently tested? It's a leukotriene receptor antagonist. Nidochromyl, anything having chrome. Nidochromyl, sodium chromoglycate, they are mast cell stabilizers. Xyluton, you can see the name. You can see the name has leukotriene, luton. It inhibits the enzyme LOX. Omalizumab, it's a monoclonal antibody which is targeting IgE. So it's a IgE blocker. Steroids are also used in asthma, but they block phospholipase acid. Please understand these drugs are for prophylaxis of asthma and bronchodilators for attack of asthma. So that is what we learned from this question. So let's move on to the second MCQ. Patient came with cough and thick white tenacious sputum. Which one of the following drugs are used in managing cough of this patient? So basically cough are two types. One is dry cough and one is wet cough. Now with the sputum, we call it as wet cough. Now for wet cough, we use mucolytics. So what is the mucolytic in the option? Codeine, dextromethorphan, levopropoxfen, bromhexin. So the answer is bromhexin. So bromhexin is a mucolytic which is used for wet cough. So this is a case of wet cough. Codeine, dextromethorphan, levopropoxyphene, all these drugs are used for dry cough. And bromhexin is used for wet cough, so the answer is D. What are the other drugs used for wet cough? The names are ambroxol. Then drugs ending with cysteine, they are nothing but acetylcysteine and a drug called carbocysteine. So what did you understand from this? We understood the drugs for cough here. Okay? Yes. Let's move on to the third MCQ. Which of the following drug used in peptic ulcer disease is an anticholinergic drug? So option A, pyranzepine. Yes, pyranzepine is the right answer. That is the anticholinergic drug. One more drug is telanzepine. These are used for peptic ulcer disease. Prazoles, any drug ending with prazole, they are proton pump inhibitors, not anticholinergics. So please understand, drugs ending with prazoles are PPIs. But don't confuse with the drug aripiprazole. This is used for psychiatric condition. It's an antipsychotic drug. Misoprostol is a prostaglandin E1 that is also used in peptic ulcer disease. Ranitidine is a H2 blocker. So among the options, what you get is option A, pyranzepine is the right answer. Let's move to the fourth question. Which of the following drug combination is not H. pylori eradication regimen? So you have four options. What is the right answer? The right answer is option C, omeprazole, clarithromycin, ciprofloxacin. This is not used for eradicating H. pylori because ciprofloxacin is not going to eradicate H. pylori. Can we use other options? Yes. What are the drugs used for H. pylori eradication? Remember, we use a PPI. We use antibiotics. The mnemonic, what you need to understand is ABC, trademark, limited. A for amoxicillin, P for bismuth, C for clarithromycin, T for tetracycline, M for metronidazole, and L for levofloxacin, not ciprofloxacin. So usually what we give the regimen is PPI plus 2 antibiotics, and that is given for 14 weeks. That is given for 14 days or 2 weeks. That is the H. pylori eradication regimen. So coming back, all the other options are correct, but ciprofloxacin is not there in the option, so that is why it is not the answer. Hope you got this. And remember the mnemonic. Okay? Yes. Moving on to fifth question. A female patient developed torticollis. What is torticollis? Neck turning to this, like this, after taking an antiemetic drug. Which of the following antiemetic is responsible for this? Yes, any guesses? Yes, if you're telling A, metoclopramide, then you are right. Metoclopramide is a D2 blocker. This crosses the blood-brain barrier, and when it crosses, it also blocks dopamine in the brain, so that will lead to acute dystonia. And the treatment for this torticollis or acute dystonia is by the drug benzhexol. Benzhexol has one more name. It is also called as trihexyphenidyl. One more option what we can give is promethazine. This is a frequently tested question. Ondansetron is a 5-HT3 antagonist. Any drug ending with pitant, it's a neurokinin 1 antagonist. So what should I remember from this? Remember, the drug of choice for early CINV is ondansetron or enisetron. Late CINV is pitants. And the last option, hyoscine, is an anticholinergic drug. It's the drug of choice for motion sickness. It's a drug of choice for motion sickness. The name is hyoscine. Now please understand the combination of doxylamine plus B6. This is a drug of choice for morning sickness. Morning sickness, it's the drug of choice. Can you tell me what the drug of choice for acute morning sickness? It is acetazolamide. Let's move on to the next question. Question number 6. Which of the following statement is false? So let us read. Adrenaline is the drug of choice for anaphylactic shock. True statement. So we use adrenaline in the dilution of 1 in 1000 and the dose is 0.3 to 0.5 milligram. And we give the drug by IM and the muscle what we prefer is vastus lateralis. Now why adrenaline is the drug of choice? Because adrenaline is a physiological antagonist of histamine. Adrenaline is a physiological antagonist of histamine. Norepinephrine, also called as noradrenaline, increases systolic, diastolic, mean arterial pressure. Remember, norepinephrine increases all the BP followed by reflex bradycardia. True. Why do you see reflex bradycardia? Because when you increase all the BP, there is stimulation of baroreceptors and that will stimulate the parasympathetic and decrease the heart rate. Dopamine is used in cardiogenic shock with oliguria at the infusion rate of 2 to 10 microgram per kg per minute. True. Remember, dopamine has different action at different levels. Low dose, medium dose, high dose. Low dose, it acts on D1 and increase the urine. Medium dose, it acts on the heart and increase the cardiac output. High dose, it acts on alpha and increase the BP. So at this dose, it can be used to manage cardiogenic shock with oliguria. So that is also true. Dobutamine acts mainly on dopamine receptor used in hypertension emergency. Remember, dobutamine doesn't work on dopamine at all. So it's a false statement. Dobutamine mainly acts on beta 1 and it's the drug of choice for cardiogenic shock. And dobutamine is also used to manage it is used for cardiac stress testing. And what is the dopamine receptor agonist used for hypertension emergency? The name is called phenoldopam. Phenoldopam is a D1 receptor agonist used for hypertension emergency. So we discussed important ANS drugs from this MCQ. Okay? Yes. Let us move on to the next question. Drug used for diagnosis of myasthenia gravis. You know, myasthenia gravis is a muscle weakness condition starting with ptosis and all. The drug to diagnose is called edrophonium. Edrophonium, it is also called by another name, tensilon test. Tensilon test. Now, physostigmine is the drug of choice for atropine poisoning. Or they can ask you as datura poison or belladonna poison. Physostigmine is the drug of choice. Pilocarpine, it is used to manage glaucoma and also it is used for Sjogren's syndrome, where you see dry eye and dry mouth. Bethanocol, remember it ends with cholinergic. Bethanocol, bathroom call. It is used for bowel and bladder problems. It is used for post-operative bladder problem called urine retention, post-operative paralytic ileus. What are the drugs used to improve muscle weakness in myasthenia gravis? The names are neostigmine and another drug called pyridostigmine. So these are used to manage myasthenia gravis. But what are the other uses of neostigmine, pyridostigmine? They are used for cobra bite and also they are used to reverse non-depolarizing skeletal muscle relaxants. So answer for question number 7 is edrophonium, that is used to diagnose myasthenia gravis. Yes. Let's move to question number 8. Drug used preoperatively to reduce BP in pheochromocytoma condition patient is. We know that pheochromocytoma is a tumor of adrenal medulla. The BP is high. The drug we use before operation is phenoxybenzamine. Phenoxybenzamine is non-selective alpha blocker and the blockade is irreversible. So that is given before surgery. Suppose the BP shoots up during surgery, that is called interoperative. Then the drug what we use is phentolamine. That is also alpha blocker. Preoperatively, phenoxybenzamine, intraoperative, phentolamine. Propranolol can also be used in pheochromocytoma, but always remember when you manage BP in pheochromocytoma, first you have to give alpha blocker, then you have to give beta blocker. So very, very important medicine question. Phenoldopaum, just now I told you, it's a D1 agonist used for hypertension emergency. Tamsulosin is a alpha 1A selective blocker. It's a alpha 1A selective blocker used to manage BPH only. But one adverse effect of tamsulosin is it can cause floppy iris syndrome. So let me tell you one more alpha blocker called prazosin. It's a drug of choice for scorpion sting. Prazosin. So we understood various alpha blockers and important points from this MCQs. Okay, sir. Let us move to the next question. Which of the following is a preferred cycloplegic in adult patient? So cycloplegia is required for refractive error testing. So the preferred one in adult patient is tropicamide because it's the shortest acting cycloplegic. But in children, the preferred one is atropine. And atropine is the longest acting cycloplegic. And phenylephrine is a mydriatic and we call it as active mydriatic. And pilocarpine is a meiotic. So what should I take away from this MCQ? Preferred mydriatic or cycloplegic in adult is tropicamide because short acting. Preferred cycloplegic in a child is atropine because in children the ciliary muscle tone is high. I need to give a strong drug atropine. Let me move to the next question. Question number 10. What describes vasomotor reversal of tail? Think and tell me. High dose adrenaline causes initial rise and then fall in BP. Is this vasomotor reversal? No. This is called biphasic response. So this is ruled out. Second, when an alpha blocker is given, and then high dose of adrenaline is given to dog in animal experiment, there is only fall in blood pressure. Yes, this is what we see when we give alpha blocker and then only adrenaline, fall in BP. That is called vasomotor reversal of tail. Then propranolol, then high dose of adrenaline causes increase in BP. No, this is not vasomotor reversal of tail. Sudden withdrawal of clonidine causes rise in BP. Yes, that is correct, but that is not the vasomotor reversal of tail. So answer for this question is option B, repeatedly tested. What describes vasomotor reversal of tail? Clear? Yes. Question number 11. Which of the following beta blockers can be preferred in a patient with bronchial asthma and hypertension? Now the problem with beta blockers is this. So there are two betas, beta 1 and beta 2. Beta 2 is present in bronchus. So if you block beta 2, there will be bronchoconstriction. So a drug blocking both beta 1 and beta 2, they are called non-selective beta blockers. Non-selective beta blockers. So non-selective beta blockers are not given in asthma patient because they block beta 2 and lead to bronchoconstriction. How to remember what are these non-selective beta blockers? Remember, all the beta blockers end with lol. And any beta blocker whose name starts from A to N, they're all cardioselective. That means they block beta 1 less beta 2. Any name starting from N to S, they are non-selective. What is N for? N for nebiolol, which is cardioselective, and N for nadolol, which is non-selective. So according to this, can you rule out? Yes. According to this, we feel labetalol, carvedilol is also answer, but no, because these are also non-selective. For this A to N rule, what I told you, labetalol and carvedilol will not come to the rule because they are alpha plus beta blockers. That means they are non-selective. So propranolol comes under NOPQ. So propranolol is a non-selective beta blocker. That also cannot be given in asthma. So what we can do is metoprolol, because it comes between the alphabet A to N. So let me tell you again how to identify the cardioselective beta blockers A to N alphabet. So M, A, B, C, D, E, F, G, H, M, N. So metoprolol is a cardioselective. Labetalol, carvedilol is an exception for the rule because they are non-selective beta blockers, and that has to be remembered. And non-selective beta blockers are not preferred in asthma patients because they can cause bronchoconstriction. I think you are clear with that. Question number 12. Which of the following antiglaucoma drug acts by increasing trabecular outflow mainly and acts by inhibiting rho kinase? So it's a new drug which inhibits rho kinase. The name is called Netra. Netra, you know, Sudhir. So it's a rho kinase inhibitor which increases trabecular outflow. Latanoprost, bimetoprost, roprost, they all belong to prostaglandin F2 alpha, and all of them increase UU scleral outflow. Timolol is a beta blocker and that decreases aqueous humor production. Pilocarpine is a miotic used in glaucoma and it increases trabecular outflow. But one thing they always test is what are the adverse effects of PGF2 alpha. Remember the mnemonic MIG. M stands for macular edema, I, iris pigmentation, G for growth of eyelash. Macular edema, iris pigmentation, growth of eyelash is seen with drug latanoprost, frequently tested. Okay. Let me move on to the 13th question. A female patient is suffering from TB, comes to you with oral contraceptive failure history. Which of the following drug might be responsible for this? Sometimes patients taking multiple drugs, there can be interactions. So she is on TB drug, she is on OCP, and OCP is not working. So this is due to a drug called rifampicin. Because rifampicin is a enzyme inducer. What happens when you give enzyme inducer? Number of enzymes increases and they metabolize the drug faster and the drug will fail. So what drug is failing here? Oral contraceptives. What they will test you in the exams is the enzyme inducers and inhibitors in pharma. There is a mnemonic for that. The mnemonic is for inducer GPRS cell phone, G for griseofulvin, P phenytoin, R rifampicin, S smoking, C carbamazepine, P for phenobarbital. Inhibitors, we have a mnemonic. Vitamin K cannot cause enzyme inhibition properly. Valproate, ketoconazole, cimetidine, ciprofloxacin, erythromycin, isoniazid, and protease inhibitors. Remember, inducers decrease the drug levels, inhibitors increase the drug levels if you give them with other drugs. Clear? Yes. Now another question, elevation of glucose by corticosteroid is counteracted by insulin is an example of. Now, chemical antagonism means there should be some chemical reaction. For example, HCl plus antacids. Then what is this? Corticosteroids. They act through nuclear receptor and increase glucose. Insulin acts through tyrosine kinase receptor and decrease the glucose. So remember, if the receptors are different, one is nuclear and one is tyrosine kinase, and the actions are opposite, then we call it as physiological antagonism. That is called as physiological antagonism. One more example for physiological antagonism is adrenaline and histamine. They act on different receptor, they produce opposite action. Competitive means same receptor, agonist, antagonist bind to the same site in the receptor. Non-competitive means same receptor, but agonist and antagonist bind to different sites. That is called non-competitive antagonism. And in your FMG, they have frequently tested physiological antagonism. Okay. Yes. Question number 15. Loading dose of a drug mainly depends on. Remember, loading dose depends on mainly volume of distribution of a drug. Again, there is a dose called maintenance dose. It depends on clearance. So please understand this repeatedly asked question. Loading dose depends on VD and maintenance dose depends on the clearance. So the answer is A. That is volume of distribution. Now moving on to the next question. Question number 16. Which of the following phase of clinical trial is carried out after a new drug is marketed? So usually what we do, first we find out the source, then we do animal study, then we do clinical trial. So when we start clinical trial, we call it as IND, investigation new drug. Then we do phase 1 trial, then phase 2, phase 3, and then we get new drug application. New drug application will get us the marketing license, and then we do phase 4 trial. Phase 4 is also called as post-marketing surveillance. So what is they asking you? After a new drug is marketed, which phase of the trial is done? After a new drug is marketed, the trial that is done is phase 4. So answer for this question is phase 4 clinical trial. I hope you got that answer. Okay, just wait. Okay, we'll move on. Question number 17. A traveler went on a trip at high altitude mountain and developed difficulty in breathing. You know that when you go to high altitude, the oxygen levels are very low and you develop hypoxia. This condition is called high altitude sickness or acute motor sickness. He was administered diuretic, considered as drug of choice for this condition. What is the site of action of this diuretic on nephron? So they are asking you what is the drug of choice for this. The name is acetazolamide. And acetazolamide is a carbonic anhydrase inhibitor. But what they are asking, which site in the kidney they work? It mainly acts on proximal convertible. So that's the answer. The drug acting on loop of Henle is loop diuretic like furosemide. Remember, it acts on thick ascending loop of Henle. DCT, the drug which acts as thiazides, and collecting the drugs working are potassium sparing diuretics. So what are the potassium sparing diuretic? You know the mnemonic paste. P for potassium sparing diuretics, A for amyloride, spironolactone, triamterene, and eplerenone. These are potassium sparing diuretics. So in detail, if I want to tell you, this spironolactone, eplerenone, they are aldosterone receptor antagonist. Amyloride, triamterene are ENaC inhibitors. What do thiazide inhibit? They inhibit sodium chloride symport. And what does furosemide inhibit? It inhibits sodium, potassium, 2-chloride co-transporter. What we need to understand from this MCQ is the diuretic of choice in these conditions. Acute mountain sickness, high altitude sickness, I just told you, acetazolamide. Pulmonary edema, LVF, nephrotic syndrome, the diuretic of choice is loop diuretic, that is furosemide. Cerebral edema, the drug is mannitol, very good. Cirrhosis and edema, the drug of choice, diuretic of choice is spironolactone. Acute congestive glaucoma, the diuretic of choice is mannitol. Lithium, when we give lithium for mania, it can induce diabetes insipidus. The diuretic or the drug of choice is amyloride. Amyloride. So all these are tested. Clear? Yes. So next question is, which of the following statements are false? Tolvaptan is used for treatment of SIADH. Yes, tolvaptan is a V2 receptor antagonist. And what is SIADH? It's an excessive ADH condition. So it blocks the V2 action. So it's a true statement. Terlipressin is a V1, it is vasopressin 1 receptor agonist used for esophageal varices. True. One more drug which is used for esophageal varices is octreotide. Remember your surgery. Amyloride for lithium-induced diabetes. True, just now we discussed. Desmopressin can be used for both neurogenic and nephrogenic diabetes insipidus. False. Desmopressin is only for neurogenic, that is called central diabetes insipidus, drug of choice. For nephrogenic, the drug of choice is thiazides. So the answer for the question is option D. Then all other statements are true statements. All others are true statements. Okay. Moving on to question number 19. Which of the following antihypertensive drug reduces proteinuria in a diabetic patient? Metoprolol is a cardioselective beta blocker, but it doesn't reduce proteinuria. Pril is a AC inhibitor, and AC inhibitors are known to decrease proteinuria. So the answer is B. One more drug which reduces proteinuria are ARBs, and ARBs end with sartans, candy sartan, irbesartan, like that. Thiazides are thiazide. Clonidine is, what is clonidine? It's a alpha 2 agonist. They are not known to reduce proteinuria, and the drug which reduces that is ACE inhibitor ARB. That's why any patient having hypertension and diabetes, hypertension and CKD, the preferred drugs are either ACE inhibitor or ARBs to reduce proteinuria or microalbuminuria. Okay? Yes. Moving on to question number 20. 56-year-old patient with essential hypertension is on ACE inhibitor for 6 months. He develops chronic refractory dry cough. What should be the correct action to be taken? Now, what is the problem when we give ACE inhibitor? They can lead to dry cough and they can lead to angioedema. Why dry cough and angioedema? Because when you inhibit ACE, the bradykinin is also not broken down, so bradykinin level increases. And increase in bradykinin is responsible for dry cough and angioedema. The best thing is stop the drug and change to some other drug. Reduce the dose of ACE inhibitor won't help. You have to stop it. Give a cough syrup. No. Change to ARB so that you can manage hypertension. Stop the drug and change to one more antihypertensive. ERBs are not going to cause dry cough and angioedema. So the answer will be C. Order a CT scan of chest. Why you want to give such a exposure to X-ray and all? Why you have to go for investigation? Just stop the drug. So the answer is option C. So what we will understand from this MCQ is the adverse effect ACE inhibitor, dry cough, angioedema. Any other adverse effect? They increase potassium, they decrease BP, but most important, they are teratogenic, meaning they are not given in pregnant women. Not only ACE inhibitor, ERBs are also not given in pregnant women. Okay. Let's move on to question number 21. Digoxin toxicity is increased by all except. Obviously, renal impairment will increase because digoxin is eliminated in kidney. Hyperkalemia, hypercalcemia, hypomagnesemia. Remember the electrolytes, that is decrease in potassium, decrease in magnesium and increase in calcium is responsible for digoxin toxicity. Hyperkalemia is not going to cause, hypercalcemia and hypomagnesemia is going to cause. So the answer will be option B, hyperkalemia is not responsible. But what should I know about digoxin? Remember, digoxin, you need to understand the mechanism of action in heart failure. It inhibits sodium, potassium, ATPase pump in the heart. And that increases the force of contraction. Second, they will ask you the antidote for digoxin overdose. And the name is Digibind, or so called as Digifab. Digoxin toxicity can lead to SVT. The drug of choice for that is beta blockers. Digoxin toxicity can also lead to ventricular tachycardia. The drug of choice is lidocaine. Lidocaine has one more name, that is lignocaine. Both are same. So this much point at least you should remember about the drug digoxin. Okay. Let's move to the second question, 22nd question. Patient present with chronic stable heart failure with ejection fraction of 35%. So there is reduced ejection fraction, heart failure with reduced ejection fraction. Which of the following drugs will not reduce mortality? So in CHF, there are certain drugs which reduce mortality. The mnemonic is SUB. S for spironolactone. And recently, SGLT2 inhibitors. A for ACE inhibitor, ARBs, and R9. And B for beta blocker. So these drugs reduce mortality in CHF. So option A, Pril, yes, it's a ACE inhibitor. Digoxin is not in the option. So spironolactone is there. The SGLT2 inhibitor, they end with gliflozin. So this is also there. So the answer is digoxin. Please remember this. Digoxin can increase the force of contraction and treat the symptoms, but it will not reduce the mortality in CHF. So that is one mistake you all do. So the answer is digoxin. Clear? Yes. Question number 23. Which of the following statement is false regarding drugs used in angina or anti-anginal drugs? Nifedipine is a CCB, which is called as dihydropyridine, causes reflex tachycardia. True. Because nifedipine acts on blood vessels, cause vasodilation, decrease the BP, and reflex tachycardia. Thrombolytics are contraindicated in non-ST elevation MI. True. So we don't give thrombolytics in non-ST elevation MI, but we can use them in ST elevation MI. Drug-free interval in nitrate is given to decrease drug tolerance. Yes, true. So when we give nitrate repeatedly, the drug may not work. That is called tolerance. To avoid the tolerance, we give drug-free intervals. The last one is nitrates are not useful in biliary colic. False. Nitrates are useful in biliary colic because they are smooth muscle relaxant. Tell me on opioid not used in biliary colic. Remember, morphine is contraindicated in biliary colic. Remember this. Nitrate can be used in erectile, but morphine is contraindicated. That is tested repeatedly. Okay. Moving on to the next question. Drug not used with tadalafil. What is tadalafil? It is like the brother of sildenafil. Both are phosphodiesterase 5 inhibitors. And tadalafil is the longest acting. So they increase the cyclic GMP and they cause vasodilation. And because they cause vasodilation, they are used for erectile dysfunction. They increase the erection duration. So which drug is not used? Amlodipine is a CCB. Isosorbate dinitrate never given with nitrate because nitrate are also vasodilators. And both of them have same mechanism. They increase cyclic GMP. So there will be severe hypotension. And you know that severe hypotension can lead to cardiac arrest. So losartan ARB. Pril is ACE inhibitor, but never ever give nitrate with pills, sildenafil, tadalafils. So the answer is B, isosorbate dinitrate. Okay? Yes. Question number 25. 35-year-old male patient present with recurrent episode of sudden onset of palpitations, dizziness and mild chest discomfort. ECG during one such episode confirmed PSVT. You know the drug of choice for PSVT. What is the drug of choice for prophylaxis of PSVT? Adenosine is the drug of choice for attack of PSVT. So that cannot be the answer. Prophylaxis means we should give oral drug. So the oral drug that can be given is verapamil. So verapamil is a CCB that can be given for prophylaxis. Beta blocker can also be used, but they are not given IV. It's like prophylaxis they are asking. Oral adenosine is not available. So the answer is verapamil. But what I want to tell you is, most of you when you see this question, you will jump to the answer adenosine immediately. But read the question carefully. They are asking drug for prophylaxis. That means either you can give beta blocker or you can give CCBs. In CCBs, you can use either verapamil or diltiazem. So the answer is B. Question number 26. Which of the following drug is used in ventricular arrhythmia and is a class 3 antiarrhythmic? How do you remember classes of antiarrhythmics? Remember, there are 4 classes and 1, 2, 3, 4. The mnemonic is saved by Pharmacology. S means class 1 drugs are sodium blockers. S for sodium, B for beta blockers, P for potassium blockers, and C for CCBs. So they are asking class 3. Lignocaine belongs to class 1B antiarrhythmics. Propranolol is a beta blocker, so they are class 2. Diltiazem is a CCB, so they belong to class 4. And amiodarone belongs to class 3, and it's the drug of choice for ventricular tachycardia. So the answer for this question is option D, amiodarone. Amiodarone is the class 3. There is one beta blocker which is also class 3, that is called sotalol. Sotalol is a beta blocker, but it is placed under class 3 antiarrhythmics. 2 adverse effects of amiodarone they will ask you. It can lead to thyroid problem, liver disease, and also lung fibrosis, and it will cause blue man syndrome. The name is amiodarone. Move to another beautiful question, 27. Remember, a patient with asthma, whenever they give asthma, you should be very careful. And hyperthyroidism, not an asthma medication, presented with anxiety. Obviously, hyperthyroidism is anxiety, restlessness, and BP is 180, 110. Heart rate is also more. And there is atrial fibrillation. What is the treatment? Patient is asthmatic. So asthmatic, you need to treat the hyperthyroidism. Esmolol, PTU, propranolol, diltiazem, and patient is having fibrillation. Atrial fibrillation, the drug what we use for rate control is either beta blocker or CCBs. They cause the AV blockade and decrease the heart. So here patient is having asthma, so I don't prefer beta blocker, I prefer CCBs. CCB, I either prefer verapamil or I prefer diltiazem. So esmolol is ruled out. Propyltyrosine won't treat atrial fibrillation. Propranolol is also a beta blocker, so not used. So what should I use? I should use diltiazem to control the rate in atrial fibrillation. So the answer will be option D, diltiazem. Clear? Yes. Question number 28. Which of the following statement is false about benzodiazepines? These are GABA facilitators, true. The antidote is fomepizole, this is false. The antidote for benzodiazepines are flumazenil. अगर फ्लू होता है तो mazenil होता है, that is for benzodiazepine. Fomepizole is an antidote for methanol poisoning. Methanol antidote name is fomepizole. It inhibits alcohol dehydrogenase. Lorazepam is safe in liver disease patient, true. Remember the mnemonic lot. Benzodiazepine safe in liver disease are lot. Lorazepam, O for oxazepam, T for temazepam. Benzodiazepines are used in acute anxiety, seizure and insomnia, yes, true. But this one is absolutely false and I know most of you make the mistake here. In any exam, the antidote is must. So here I have given a list of antidotes. After this session, we will give this PDF. Please go through this antidote list. Never miss it. Okay. Question number 29. Which of the following drugs are not used in management of anxiety? Lorazepam or any benzodiazepine, they are the drug of choice for acute anxiety. Fluoxetine is a SSRI. Buspirone is a 5-HT1A partial agonist. These two drugs, option B and option D, they are used for chronic anxiety. And for chronic anxiety or general anxiety disorder, the drug of choice are SSRIs like fluoxetine. So lorazepam is used, fluoxetine is used, buspirone is used. What is not used is zolpidem. So the answer is zolpidem. Zolpidem belongs to Z drugs. And Z drugs are used for insomnia only. They are not for anxiety, they are for insomnia only. And remember, buspirone, most of you will confuse. Snake. You see the snake, you get anxiety. Don't confuse with the drug bupropion, which is used in smoking cessation. Don't confuse with that. Okay. Yes. Moving on to question number 30. Which of the following COMT inhibitor is used in Parkinson disease? You know, Parkinson means tremors, rigidity, bradykinesia. So COMT inhibitor is option A, capone. Anything ending with capone is a COMT inhibitor. Anything ending with gilin is a MAO-B inhibitor used in Parkinson disease. Even a new drug, safinamide, is a MAO-B inhibitor. The other drugs what we use for Parkinson is levodopa plus carbidopa. Then we also use D2 agonist. One is bromocriptine, cabergoline. The other D2 agonists are pramipexole, ropinirole, rotigotine. Let me repeat their name. Pramipexole, ropinirole, rotigotine. Just remember Rami, Ropi, Roti like that. So these are drugs used in Parkinson's disease. So COMT inhibitors end with capone, mobigelin, D2 agonist I told you, levodopa plus carbidopa. Okay. Question number 31. Which of the following conditions and drug of choice are incorrectly matched? So again, the seizure conditions are frequently tested. Generalized tonic-clonic seizure, the drug of choice is valproate, true. Myoclonic seizure, phenytoin, false. Phenytoin is contraindicated in myoclonic seizures. Childhood absence seizure, ethosuximide, true. And eclampsia, magnesium sulfate. So the answer is B. Now, moving on to some epilepsy conditions, what they will ask you is febrile seizures. The drug of choice is intranasal midazolam. If that is not there, you can give rectal aspirant. Then infantile spasm, ACTH. But again, the important thing they will ask you is status epilepticus. So first we give lorazepam or thiazepam. Still patient is not responding. We have three options. Fosphenytoin, valproate, levetiracetam. Any of these. Still not responding, we give phenobarbital. So the last resort will be general anesthesia, either with midazolam or propofol. So this is again tested frequently. Status epilepticus management. Okay. Let's move to question number 32. Patient after consuming alcohol started experiencing vomiting, abdominal pain and chest pain on examination. The patient was hypertension. What is the drug causing these symptoms? So patient is taking some drug and drunk alcohol. So the drug what is being taken is metronidazole. And we call it as disulfiram reaction. So remember, if somebody is on metronidazole, they should not drink alcohol. They may experience disulfiram like symptoms. And it inhibits an enzyme called aldehyde dehydrogenase. The name is disulfiram. Moving on to question number 33. Which of the following drug acts by inhibiting cell wall synthesis? Remember the names beta-lactams, daptomycin, sulfonamide, ciprofloxacin. The drug which inhibits cell wall synthesis is beta-lactams. In beta-lactams, remember two drugs, penicillins and cephalosporins mainly. And one more drug which targets cell wall is vancomycin. They inhibit cell wall. Daptomycin and polymyxin, their target is cell membrane. CM means cell membrane. Sulfonamides, they inhibit dihydroteroate synthase. And fluoxetine, fluoroquinol, they inhibit DNA gyrase mainly. So this is the mechanism of action. Other drugs like tetracycline, chloramphenicol, macrolides, azithromycin, clindamycin, aminoside, all of them inhibit protein synthesis. So keep that in the mind. Among these antibiotics, which are cidal, remember mainly the beta lactams, then vancomycin and fluoroquinolone. These are cidal drugs. All others usually are static in nature. So the answer for this question is A, beta lactams. Question number 34. Which of the following statement is false? Ciprofloxacin causes cartilage damage. Correct. Stevens syndrome, not SIS, it is Stevens syndrome. Tendon rupture in elderly and diarrhea. True. What is frequently tested is cartilage damage and tendon rupture. Imipenem plus cilastatin combined is given to prolong duration of action of imipenem. True. That's why you give imipenem plus cilastatin. Cefoperazone causes disulfiram reaction bleeding. True. Just now I told you metronidazole can cause disulfiram. Similarly, cefoperazone can also do that. Doxycycline needs dose reduction in renal failure. False. Doxycycline doesn't require any dose reduction in renal failure. So remember, option D is false. It doesn't require any dose reduction. If a newborn baby has cartilage abnormality, history revealed mother had taken an antimicrobial for UTI. Which of the following drug could be possible for baby condition? So they are asking which antibiotic has caused cartilage damage. Now remember, all these options A, B, C, D, they are all going to cause problem in the baby. Tetracycline, they can cause problem for teeth and bone. Aminoside for ear oto, and ciprofloxacin cartilage damage. All these three are teratogenic and avoided in pregnant women. Tetracycline, aminoside, fluoroquinolones are avoided. Sulfonamides, if you give in last trimester, can lead to bilirubin displacement, and that can lead to carnivorous, but it is not a teratogenic one. Which one is safe in pregnant women? Antibiotics. Remember the mnemonic PCM. P for penicillins are safe, cephalosporins are safe, macrolides are safe. These are safe in pregnant antibiotics. Okay. Question number 36. 30-year-old male came with fever, headache, and nuclear. So fever, headache, nuclear means meningitis. Lumbar puncture shows gram-negative diplococci on gram stain. So negative diplococci means it is meningococci, which is the drug for chemoprophylaxis of close contacts. Amoxicillin, doxycycline, ethambutol, no, it is rifampicin. 3 drugs are given for chemoprophylaxis of meningococci. Number 1, ciprofloxacin, first option. Rifampicin, ceftriaxone. These are the 3 options for prophylaxis of meningococcal meningitis. What is the drug of this meningococcal meningitis? If they ask you, it is ceftriaxone. So here the better answer is rifampicin. Okay. Yes. Moving on to question number 37. A patient on treatment for MDR TB present with tingling and numbness. Which of the following may be responsible? Bedaquiline inhibits ATP synthesis in the mycobacterium, and it has 2 adverse effects. It can cause QT prolongation. It can cause hepatotoxicity. Pritomanid inhibits the mycolic acid synthesis. That means it inhibits cell wall. Again, the drug causes QT prolongation. Linezolid can cause bone marrow depression, and also it can cause peripheral neuropathy. And this peripheral neuropathy is responsible for tingling and numbness, so the answer will be C. And the treatment for this is B6 pyridoxine. Moxifloxacin is a fluoroquinolone which can cause allergy, Stevenson syndrome, cartilage damage, then tendon rupture like that. So this is the regimen. You can see B, PAL, M regimen. But what they test you is, what are the most common adverse effects of the first line drugs, HRZD? HRZD, all these HRZD, all are hepatotoxic. Correct. But remember, this can also cause peripheral neuropathy, and the treatment for that is B6. Rifampicin, remember it starts with R, so it causes red color. And the red color is also called as orange red color. So it can make the secretions orange red, urine orange red, everything orange red. Pyrazinamide starts with P, so it causes pain, wedge pain, joint pain, because it increases uric acid. Ethambutol starts with E, so it causes eye problem, eye, retrobulbar optic neuritis, so patient will complain red-green blindness, decrease in vision. So this is the important aspect about anti-TB drugs. Okay. Question number 38. 32-year-old patient present with complaints of reddish black discoloration of skin and body secretion. Which antimicrobial agent can cause this condition? Just now I told you rifampicin can do that problem, but one more drug which can do that is clofazimine. It's a drug used for leprosy and also nowadays for MDR TB. It is basically a dye, that's why it can cause discoloration of secretion. Cycloserine, we call it as cycloserine, that is used for TB, causes psychosis and seizures. So capreomycin is an aminoglycoside. You know, all the aminoglycoside can cause ototoxicity, nephrotoxicity, and neuromuscular blockade. Ciprofloxacin we already discussed. So the best answer will be clofazimine. Why it causes discoloration? Because it's a dye. Dye means coloring agent. That's why. We go to question number 39. Which of the following is the drug of choice for induction phase of cryptococcal meningitis? Repeatedly asked. Cryptococcal meningitis, the drug of choice for induction phase is liposomal amphotericin B plus flucytosine. After that, we use maintenance therapy with fluconazole. Okay. So what we will understand from here is the drug of choices in this question. I already told you the drug of choice for this. Mucormycosis, it is LAM. LAM means liposomal amphotericin B. Pneumocystitis cerevisiae, it is cotrimoxazole. Histoplasmosis, chromoblastomycosis, porotrichosis, it is itraconazole. Then cryptococcosis, candidiasis, coccidioidomycosis, it is fluconazole. But aspergillosis tested, the drug of choice is oriconazole. Allergic bronchopulmonary aspergillosis, we use steroid and antifungal, that is itraconazole. We had itraconazole for that. So what we learned from this MCQ is various fungal infection and their drug of choices. So please pause the video and try to study this. Okay, let me take question number 40. 50-year-old male patient had a fever for 1 week, abdominal distension and loss of appetite. It is not responding to antibiotics and anti-malarial. It's not an infection, it's not malaria. Usually abdominal distension is due to hepatosplenomegaly. Vidal is also negative, but RK39 dipstick test was positive. What drug can be used? So it's an integration between micro and pharma. Where do you see RK39 dipstick positive? You see it in visceral leishmaniasis, also called as Kala ulcer. What is the drug of choice for Kala ulcer? The answer is liposomal amphotericin B. That is the answer. So this is how they integrate from micro and ask the pharma question. The answer is liposomal amphotericin B. Moving on to question number 41. Which of the following statement is false? Tafenoquine is used as single dose for radical cure due to long half-life. True, because tafenoquine acts for 14 to 19 days. So a single dose is enough. Primaquine is contraindicated in G6PD patient and pregnant. True. Artesunate is used for causal prophylaxis of malaria. False. Artesunate is very important drug in malaria. We don't give for prophylaxis. We give it only for treatment. Chloroquine can cause corneal deposits, bullseye maculopathy, and skin and mucous membrane pigmentation. True statement. So the answer for this question is option C. It can be used. But what I want to discuss from this MCQ is treatment of malaria, which is frequently tested. Plasmodium vivax, oval, Plasmodium falciparum. Vivax and oval, same treatment. So we use chloroquine plus primaquine. But chloroquine is for 3 days and primaquine is for 14 days for radical cure. For Plasmodium falciparum, we use ACT regimen, that is called artemisinin combination therapy. So it depends on which part of the country you're treating, northeast or rest of India. Northeast, we use artemether plus lomifantrin. Remember Mimi, northeast. Rest of India, artesunate plus sulfadoxine pyrimethamine combination. For falciparum, we give single dose of primaquine to kill the hypnocytes. So this is how we manage malaria. Suppose the malaria is complicated malaria or cerebral malaria. How do you know that is cerebral malaria? Seizure, confusions, delirium. Then the drug of choice is IV artesunate. Then again the question will be, what if the malaria in pregnancy? Suppose it is Vivax and oval in pregnant women. That time we don't give primaquine. Okay. In case of Plasmodium falciparum, in first trimester, we give quinine plus clindamycin. Second and third, we follow the same. Trimesters. What happens if there is a complicated malaria in pregnant women? There also drug of choice is IV artesunate. Again, one more question they will ask you in malaria is prophylaxis. Two drugs are used, doxycycline and mefloquine. So it is started before journey, continued throughout the journey, and coming back, you have to continue for another 28 days. It's a start, it's the end. You have to take doxy daily. Mefloquine, this is the start, this is the end, but you can take once weekly, and coming back you have to take for another 4 weeks. So these are very, very important. Prophylaxis of malaria. If your journey is less than 6 weeks, prefer doxy. More than 6 weeks, prefer mefloquine. And mefloquine is longer acting. So should that drug be taken even after leaving the endemic area? Yes. Doxy for 28 days and mefloquine for 4 weeks. So we'll take up the question number 42. 62-year-old male complains of severe burning pain or right half of the back from 2 days. The examination showed lesions as in the image here. The affected region is tender to touch and red. Which of the following drugs should be prescribed? See this. Derma question. Herpes zoster. For herpes zoster, the drug of choice is acyclovir or val acyclovir, both are same. So this is the drug of choice for herpes 1, herpes 2, and varicella zoster virus. Ganciclovir is the drug of choice for cytomegalovirus. Oseltamivir is the drug of choice for influenza. Both A and B is the drug of choice. Tenofovir used in HIV also, but it's also drug of choice for hepatitis B. So in one exam MCQ, we have covered drug of choice for various virus infections. Okay, so we'll take 5-minute break and we'll resume. Have a break. Okay, welcome back after the break. So let's move on to the next 43. An intern had needle prick injury while drawing blood from HIV positive patient. Which of the following is false about post-exposure prophylaxis? Now, this is a case of post-exposure prophylaxis. So we have to find out false. The treatment has to be taken within 72 hours. True. Minimum 3 drugs should be given. True. Duration is 8 weeks. False. The duration is only 28 days. That means 4 weeks. And TLD, tenofovir, lamivudine, dolutegravir is the best combination. True statement. So the false one is duration, that is only 28 days. One more they ask you is prevention of parent to child transmission, that means mother to child. Suppose pregnant woman, she is HIV positive, viral load is high, and also no drug, no treatment. She delivered the baby. For this baby, what prophylaxis I should give? I should give only nevirapine, or I should give one more. I should give nevirapine with zidovudine for 6 weeks. Because she is not in any treatment, she is having high viral load, so better to give 2 drugs in this high risk. Second case, pregnant woman, HIV positive, she is taking treatment and virus load is less. For this, if the baby is delivered, the baby should be given only nevirapine, that too for 6 weeks. This is again tested frequently in your FMGE exam. So malaria, HIV, TB are tested. Again, this one, integration with microbiology. Identify the parasitic infection occurs due to consuming raw or undercooked organism as shown in the image. What is the drug of choice for that parasitic infection? What you are seeing is crab. Now, what parasitic infection occurs when you eat raw or undercooked one? The infection is Paragonismus westermani, which is called as lung fluke. So what is the drug of choice for lung fluke? The answer is B, praziquantel. The answer is praziquantel. So what we have done is, we have given the drug of choices here, helminths. Please understand cestodes. For all the cestodes, the drug of choice is praziquantel. You take solium, sejanita, tapeworm, nana. But neurocystic sarcosis and hydatid, the drug of choice is albendazole. For all nematode, the drug of choice is albendazole. But for filariasis and lova, it is DEC. Strongyloidosis and onchocerciasis, it is ivermectin. Ivermectin is also used for scabies. Cutaneous larva migraines, ivermectin. Visceral larva migraines, albendazole. For all the flukes, the drug of choice is praziquantel except liver fluke. What is the other name for liver fluke? Facial hepatica, it is triclopendazole. So we learned the drug of choices from this MCQ. Okay, so this is the one. That is about question number 44. Let us go for question number 45. A cancer patient was on chemo with cisplatin. After therapy, his leukocytes are depleted, leading to leukopenia. Which of the following drug will increase the levels of WBC? Option 1, oprelvacin. It is interleukin 11 analog. Now this is given if you find out thrombocytopenia due to anti-cancer drugs. So here it's not thrombocytopenia. How to remember? Remember, it's an interleukin, so it ends with kin. What is the number of interleukin? 11. So there is 11. Then we have filgrastim. It is filgrastim So it is GCSF analog. So G for granulocyte stimulator, and that can be used for managing this. So the answer is B. One more drug similar to that is sargramostim. It's a granulocyte monocyte stimulator. It's a GM-CSF analog that can also be used in this patient. Anything ending with poietin, it's erythropoietin. So it can be used for anemia due to cancer drugs, anemia due to CKD. Loperamide can also be used for cancer-induced diarrhea. Anti-cancer drug induced diarrhea, it can be used. So let us revise one more thing. What are the drug of choice for early CANV? Cetron. Late pitant. Yes. Now sometimes cancer can induce thrombosis. What is the prophylactic drug to prevent cancer-induced thrombosis? It is low molecular weight heparin. So this is frequently tested in your exams. The common adverse effect and how do you manage in anti-cancer treatment. So here the answer is filgrastim. Let's move to question number 46. Which of the following drug causes hemorrhagic cystitis? The drug which causes hemorrhagic cystitis is option A, cyclophosphamide. Cyclophosphamide. Now bleomycin, methotrexate, what is the common problem? Let us tell you. Methotrexate can cause hepatotoxicity. So what monitoring you want to do? You want to monitor LFT. Second, the drug can cause an anemia due to folic acid deficiency, that is called megaloblastic anemia. So that's why we give folic acid supplement when we give methotrexate. Bleomycin, two problems. What are the two adverse effects? Lung fibrosis and flagellate dermatitis. Flyfluorouracil can cause hand foot syndrome. This is tested frequently, and also it can cause thymidine less cell death. It is 5-fluorouracil. Yes, these are the adverse effects. And this is the chemoman, which gives a common adverse effect of anti-cancer drug. Remember this cisplatin, carboplatin, they cause ototoxicity and nephrotoxicity. Then vincristine, vincalcolides, they cause peripheral neuropathy. The bleomycin and busulfan, they cause lung fibrosis. The donrobustine, doxorubicin, trastuzumab, they cause cardiotoxicity. CY, cyclophosphamide, cause hemorrhagic cystitis. Now, can we prevent hemorrhagic cystitis? Yes, we have a drug called Mesna that will prevent. Can you prevent methotrexate toxicity? Yes, we have something called folinic acid, also called as leucovorin, that can be used. Can we prevent cardiotoxicity by doxorubicin? Yes, we have a drug called dexrazoxane, which is a iron chelator. It's a dexrazoxane. So this is how the questions are framed. And most widely used anti-cancer drug is cisplatin. Yes. 12-year-old girl comes to the physician for follow-up after treatment with methotrexate for acute lymphoblastic leukemia. Stool analysis reveals blood in stool. Her platelet count is very low. Which of these substances should administered immediately? So she is on methotrexate. for cancer, and she is having anemia symptoms, platelet low. So we have to give an antidote. Antidote for this methotrexate is folinic acid, also called as leucovorin. Others have I discussed. Dexrazoxane for rubicins, Mesna for cyclophosphamide, Hemifostin is a radioprotected drug. Not only that, it is also helpful for cisplatin induced nephrotoxicity. There also we give the drug Hemifostin. So answer is B, folinic acid. Same thing we discussed, we have this concept. Okay, yes. Question number 48. Which of the following chemotherapeutic agent inhibits polymerization of microtubules but is not associated with bone marrow suppression significantly? See, remember, all the anti-cancer drugs, they suppress bone marrow. But some are bone marrow sparing. Remember the names: vincristine, bleomycin, L-asparginase. They are bone marrow sparing. That means they cause less bone marrow suppression. So they are asking that option. So the answer is vincristine. Not only that, it also affect the microtubules. Paclitaxel also affect the microtubules. Remember, paclitaxel stabilize the microtubules. Vincristine destabilize the microtubules. Cisplatin damages DNA. Cyclophosphamide also damages the DNA. So this is the mechanisms of various anti-cancer drugs. Okay, so the answer is vincristine. Yes, Abhijit Singh, you're right. Question number 49. A 23-year-old female underwent kidney transplant. After 8 days, she suffered with acute rejection. She was successfully managed with tacrolimus and one more drug which suppressed B and T lymphocyte, drug which target both B and T by inhibiting IMP dehydrogenase E's. IMP stands for inosine monophosphate dehydrogenase. So it's a case of transplantation. We use immunosuppressant. The immunosuppressant which inhibit IMP dehydrogenase, the name is called mycophenol mofetil. Methotrexate inhibits the enzyme dihydrofolate reductase. Tacrolimus is a calcineurin inhibitor. Cyclosporin is also a calcineurin inhibitor. These are used for as immunosuppressant drugs. What are the other immunosuppressants you need to know? Azathioprine, cyclophosphamide, steroids. These are immunosuppressant drugs. So the answer is A, mycophenolate mofetil. Moving on to question number 15. Which of the following is an interleukin 6 blocker used in rheumatoid arthritis? So in rheumatoid arthritis, we use drugs which are called DMARDs, disease modifying anti-rheumatoid drugs. So this is a frequently tested one. Abatacept or a drug called belatacept. These are CD80/86 inhibitors. They are called co-stimulation inhibitors. Tocilizumab, sarilumab. These are IL-6 blockers. So the answer for this question is option B. Tofacitinib और एक है baricitinib. जो निब से एंड होता है, they are drugs which are given orally and they inhibit the enzyme or receptor JAK. रिमेंबर लाइक दिस, तोहफा बार बार किसको देना है? जैक को. देन इनफ्ली ice age, certolizumab, then adalimumab, golimumab, and etanercept. These are TNF alpha blockers. They are also used for rheumatoid arthritis. But when you are giving this TNF alpha blocker, you have to rule out cancers, you have to rule out HIV, sorry, you have to rule out hepatitis B, and you have to rule out tuberculosis, because they can flare up the cancer and infections. So remember the mnemonic for TNF alpha blocker, ice age. The song is Infli, Adali, Sertoli, Goli, like that. Okay, so we're done with question number 50. Question number 51. 28-year-old male, each year in the spring he develops a runny nose, itchy, watery eyes, and sneezing. That means the case of allergy, and particularly allergic rhinitis and allergic conjunctivitis. He is now being given an antihistamine for the same. He had palpitation and ECG show QT prolongation, arrhythmias. Which antihistamine was prescribed? Any guess? Cetirizine, estimazole, fexofenadine, doxylamine. So estimazole is responsible for QT prolongation. Remember, estimazole and terfenadine. These two are antihistamine which cause QT prolongation, and they have been banned already, but still they are asked. In antihistamine, you should know two difference between first generation and second generation. First generation cause sedation. Second generation, they don't cause. First generation have anticholinergic property. Second generation have no anticholinergic property. So cetirizine and fexofenadine are second generation, and the least sedation among second generation is fexofenadine. Doxylamine belongs to first generation, but it is tested along with B6 for a drug of choice condition. Doxylamine with B6 is a drug of choice for morning sickness. So this much point you need to remember from antihistamines. Okay, yes, let's move. Question number 52. 55-year-old male patient, history of MI, and comes to the clinic with attack of migraine. Which of the following drugs should not be given to this patient for treating? So sumatriptan, ibuprofen, lasmiditan, ondansetron. Triptans, they are 5-HT, 1B, 1D agonist. And a patient is coming with acute attack of migraine, and you know that they are the drug of choice. So can I give? Let us see. These cause vasoconstriction. They decrease the action of CGRP. They decrease nausea and vomiting. But the patient is having myocardial infarction, old history. So vasoconstriction may be a problem. So I cannot give it. Similarly, one more drug I cannot give if a patient is having MI history, that is ischemic heart disease, is ergot, because they also cause vasoconstriction. These are not given. Then what is the drug what I can give? Suppose a patient is acute attack of migraine, and still I can give if he has migraine and ischemic heart disease is lasmiditan. So the answer is C, because it's a 5-HT1F agonist. And it doesn't cause vasoconstriction, it only decreases the action of CGRP. So the answer for this question will be option C. If you have not read this myocardial infarction in the question, then everybody would have marked sumatriptan. So I can go with lasmiditan. Can I use ibuprofen? Yes, NSAIDs can be given in acute attack of migraine, but not the drug of choice. Cetrons or antiemetics, I can give it. But the best option, what is the question asking? What should not be given? So what should not be given? is option A, sumatriptan should not be given. But what can be given is lasmiditan, ibuprofen, ondansetron, but cannot be given is sumatriptan. Yes, correct. Yes, you are right, Prathamesh. Correct. Sumatriptan is the answer. So again, they may ask you ergots, which are not given. Okay. Question number 53. A patient had pain and redness in grade 2. So whenever they give pain and redness in grade 2, go for gout. His uric acid levels were high. The doctor gave painkiller, analgesic for pain, and drug for prophylaxis. The drug acts by inhibiting uric acid synthesis. The drug may inhibit following enzyme. So you know from physio this thing, biochemistry. Xanthin will give rise to uric acid. And the enzyme name is xanthin oxidase. So this uric acid, if it is high, can get deposited in the joint and cause gout. So we inhibit this, and the drug name is allopurinol. So I call it as allopuri, and one more drug is called febuxostat. So these two drugs are drug of choice for chronic gout. So the question is not asking what is the drug of choice. The question is asking which enzyme is inhibited by these drugs. The enzyme name is xanthin oxidase. So the answer is B. Now uric acid is converted into allantoin, and that is in birds, not in us. The enzyme name is uric acid oxidase. So humans don't have this enzyme. We made the enzyme. The name is pegloticase raspberricase. So these are also given for gout. What drug inhibits carbonic anhydrase? You all know. The name is zolamide, that is acetazolamide. Glucarpidase, if you are not updated, it's also used for methotrexate toxicity. Glucarpidase. So what we understood from this chart is drugs for chronic gout. One is xanthin oxidase inhibitors and the enzymes. One more group of drugs for chronic gout, and they are called uricose-uric drugs. And the name is P for probenecid, B for benzbromone, S for sulfenpyrazone, and L for lesinuride. At least remember the names probenecid and lesinuride for chronic gout. What about the drugs for acute gout? For acute gout, the drug of choice are NSAIDs. Apart from that, we can give colchicine. Colchicine inhibits microtubules and inhibit neutrophil chemotaxis. Rarely we use steroids, and if you are giving steroid, we give it into the joint, intra-articular. So the drug of choice are NSAIDs. But one NSAID is contraindicated in acute gout, and that is aspirin. Why aspirin is contraindicated in acute gout? Because aspirin itself increases uric acid. So we don't give aspirin in this case. So what did we learn from this MCQ? Drugs used to manage gout. Okay. Question number 54. A patient with postpartum hemorrhage has a history of ischemic heart disease. Which of the following drug is not used in this patient to manage PPH? See, please understand, if a person is having ischemic heart disease, I should not give the drugs which are vasoconstrictors. So remember, a mnemonic case drug should not be given. What are the case drugs? Case means cocaine, amphetamine, sumatriptan, ergots. These should not be given if a person is having ISD or uncontrolled hypertension. This is tested frequently, so you should be knowing that. Case cocaine, amphetamine, sumatriptan, ergots. Just now we discussed that in migraine. So the lady is having PPH and ischemic heart disease, which we should not give is ergot, that is methyl ergometrin. So the answer is A. I cannot give it. Can I give carbaprost? Yes. Oxytocin? Yes. Misoprostol? Yes. Carbaprost belongs to PGF2 alpha. Oxytocin is safer. Misoprostol belongs to PGE1. All these four drugs can be used to manage postpartum hemorrhage. Please note down. Now my question to all of you, can we give carbaprost if a lady is having PPH and she is asthmatic? So tell me yes or no in the comment section. Waiting for your answers. No, carbaprost is not given. Reason is carbaprost is a PGF2 alpha analog and that causes bronchoconstriction and worsens the asthma. So we don't give in this. That is another case they can ask you from OBG. Please note down that. Yes, Abhijit Singh, you're right. No. Yes, Prathamesh, you're right. Question number 55. 34-year-old woman, 3 days postpartum after cesarean section. Okay, postpartum, 3 days later. Has multiple risk factors for venous thromboembolism, including obesity, and she is obese and she is prolonged bed rest. She is hemodynamically stable and breastfeeding her baby. Which of the following is the drug of choice to prevent postpartum venous thromboembolism in this patient? Aspirin is mainly for arterial clot. Warfarin is not safe in just now they are delivered mother, that is postpartum. The safest what we can go for is low molecular weight heparin. Clopidogrel is an antiplatelet drug. So the best one what I can give for postpartum prophylaxis is low molecular weight heparin. One thing they keep on testing you is pregnant woman. She has prosthetic heart valve. Remember, prosthetic heart valve means the risk of clot is more. So you have to give prophylaxis. So remember, for 0 to 12 weeks, what prophylaxis? 12 to 36 week, what prophylaxis? More than 36 week, what prophylaxis? 0 to 12, best one is low molecular weight heparin. 12 to 36 is oral warfarin. And again after 36 week, switch back to low molecular weight heparin. So this is the best one what we can do in pregnant women with prosthetic heart valve. That is tested. Okay, coming to the next question. A patient, question number 56. A patient presented to the emergency with BP of 220 by 130, very high. The non-contrast CT shows intracranial bleed, so it's an emergency. Which of the following drug is avoided among the following? Tenecteplase, tranexamic acid, nicardipine, labetalol. So it's a case of hypertension emergency. How emergency, sir? BP is high, sir. There is damage, intracranial bleed. You can give nicardipine, you can give labetalol, but can you give tenecteplase? Tenecteplase is a thrombolytic. And you know thrombolytics can induce bleeding. Already there is a bleeding. Will you use tenecteplase? No. So tenecteplase cannot be given. Can you use tranexamic acid? No issues. Can be used. But absolutely which should not be used is thrombolytic because already there is a bleeding issue. So avoided is tenecteplase. Right. So what I want to tell you here is certain anticoagulant and their antidotes. Heparin, low molecular weight heparin, the antidote name is protamine sulfate. Warfarin, vitamin K. Dabigatran, it is Idarucizumab. Apixaban or any exabans, then it is and hexanet alpha. These are for anticoagulants. Suppose there is overdose of tenecteplase, fibrinolytic overdose. Then the antidote name is antifibrinolytics. The name is tranexamic acid or ECA, epsilon aminocapric acid. So this is how the questions keep on coming. Right, so the answer for this question is A, tenecteplase. Okay, yes sir. Question number 57. 45-year-old diabetes 2 patient is on anti-diabetic drug. He forgot to take meals and went to gym. He started experiencing sweating, palpitation and tremors, and the blood glucose was very low, 60. Which of the following anti-diabetic drug used as monotherapy can cause hypoglycemia? Sitagliptin, metformin, glimepiride, pioglitazone. What's your answer? The answer for this question is glimepiride. It's a sulfonylureas. So there are diabetic drugs which cause hypoglycemia. What are those? So if you read the case, you will find out this is a case of hypoglycemia because tremors, sweating, and palpitations. The drugs which can cause are insulin, sulfonylureas, and Mg for meglitinides. So the answer will be glimepiride. Yes. Moving on to question number 58. Which of the following anti-diabetic drug and mechanism of action is incorrectly matched? Glimepiride inhibit ATP sensitive potassium channel in the beta cells of pancreas. True. Metformin, drug of choice for type 2 diabetes, decrease hepatic glucose output. It's an insulin sensitizer. True. Pioglitazone, it's a PPR gamma agonist and insulin sensitizer. True. Acarbose, it's a GLP-1 agonist. No. Acarbose or any bose, they are alpha glucosidase inhibitors. So it's a false statement. Answer is D. What are GLP-1 agonists? The drugs end with natide like hexanatide, or they end with glutide like liraglutide, semaglutide. They are GLP-1 agonists. Again, what drugs will increase GLP-1 and GIP? They are called gliptins. Gliptins, they inhibit an enzyme called DPP4. That stands for dipeptidyl peptidase 4. Again, they will test you what drugs are SGLT2 inhibitors. They end with the name gliflozins. Gliflozins, EMPA, DAPA, canagliflozins. So this is about mechanism of various anti-diabetic drugs. Moving on to the next question, 59. Which of the following anti-diabetic drug and adverse effect is incorrectly matched? Metformin, commonly used drug, causes lactic acidosis, unexplained diarrhea. True. Pioglitazone increases the risk of bladder cancer and fracture risk. True. Gliflozins, which are SGLT2 inhibitors, they lose glucose, that is called glycosuria. Because of that, they can cause UTI and genital myocardial infection. True. Insulin causes weight loss. No, insulin causes weight gain. So this is a false one. The answer is D. So what drugs can cause weight gain? sulfonylurea, insulin, meglitinide, and pylorozone. All of them cause weight gain. Who cause weight loss? Then loss is done by SGLT2 inhibitors, GLP-1 agonist, and pramlintide. They cause weight loss. Since they cause weight loss, nowadays there are other drugs of diabetes approved for obesity. What are the drugs? Liraglutide, semaglutide. These are diabetic drugs approved for obesity also. Now tell me in the comment section, what drug inhibit an enzyme lipase? It is used for obesity, but the adverse effect, what does it cause, is steatorrhea. Yes, can you tell me the name of a drug used in obesity which can cause steatorrhea and inhibits the enzyme lipase? Yes, if you're telling orlistat, then you're right. It is orlistat. Right. So let us move on to the next question. Question number 60. Which of the following anti-diabetic drugs are approved for obesity? Tirzepatide, semaglutide, liraglutide, all of the above. Please understand all of the above. Liraglutide, semaglutide are GLP-1 agonist. And tirzepatide is a recently approved drug which is GLP-1 and GAP agonist. So all these three are approved for obesity, and obesity is a hot topic, so questions come from that. Please study that. Okay. Yes. Let us move on to the next question. Which of the following drug is not used in the management of Cushing's disease? What is Cushing disease? The problem is in the pituitary. Pituitary is stimulating the adrenal gland to produce steroids. So steroid is synthesizing. What drug is not used? Metotane is used. Ketoconazole is used. Metoprolol is used, because all these drugs inhibit steroid synthesis. So Cushing disease, already steroid is less high. They inhibit that. Deflozacort itself is a steroid. So already Cushing disease steroid is high. Will you give deflozacort? No. So deflozacort is the answer which we don't give in Cushing disease, because it itself is a steroid. And also, how to identify steroid in the exam? Either they have caught in the name or they have shown in the name. Dexamethasone, prednisolone, like that. Okay, got it? Okay. Let's move on to question number 62. Which of the following is a growth hormone receptor antagonist used in acromegaly and causes vision impairment? Octreotide is also used for acromegaly. It's a somatostatin analog. But that is not the answer. The answer is pegvisomant. So remember, pegvisomant as VI, vision impairment. Somant means it's a growth hormone antagonist. Cabergoline, chromocriptin, they are also D2 agonist, which can also be used in acromegaly. So all the options are used in acromegaly, but the answer is pegvisomant, because they are asking which is the growth hormone receptor antagonist. This bromocriptine, cabergoline, they are also used for hyperprolactinemia conditions. and also used for infertility cases. Infertility due to hyperblactemia, there we use bromocriptine cabergoline. Clear? Yes. Let's move on to question number 63. Which of the following drug and its use are wrongly matched? Leuprolide is a GnRH agonist given continuously in prostate cancer. Now, GnRH agonist, the names end with relin, or there is a separate drug leuprolide. They are GnRH agonist. When you give them continuously, they decrease FSH, LH, testosterone, and estrogen. Since they decrease testosterone, we can use them in prostate cancer. True. Anything ending with relix, it's a GnRH antagonist used in prostate cancer. That is also true. Relin, goserelin is a GnRH agonist used pulsatile in uterine fibroids. Now, when you give an agonist in pulsatile, they increase the estrogen levels. So, should we increase estrogen in fibroids? No. So, if you want to treat fibroids, you have to give it continuously and decrease estrogen. So, it's a false statement. Then, elagolix is a GnRH antagonist used to decrease pain in endometriosis. Again, it's a true statement. So, the answer for this question is option C, which is a false statement. And any confusion you can ask here. Okay. Yes. Coming to question number 64. Which of the following is not an indication of octreotide? I told you it's a somatostatin analog. It can be used in esophageal varices, acromegaly. It can be used in insulinoma and glucagonoma. But it's not used for bloody diarrhea. It's used for diarrhea, that is secret diarrhea. Diarrhea due to carcinate tumor or VIP tumor, not for bloody diarrhea. So the answer is option D. You can use it in esophageal varices, acromegaly, insulinoma, glucagonoma, but not in bloody diarrhea. It's in secret diarrhea. That's it. That is question number 64. Moving on to question number 65. Which of the following drug and its use are wrongly matched? So why we made this question? So that we can cover the concept in one MCQ. Atosiban is an oxytocin receptor antagonist used as uterine relaxant. Yes. Remember, atosiban sounds like oxytocin ban. Oxytocin causes uterine contraction. Antagonist will cause relaxation. True statement. Tesamorelin is a growth hormone releasing hormone analog used in HIV-associated lipodystrophy. It's a true statement. It's a new update. Please write down that. Tesamorelin is a growth hormone releasing hormone used in HIV-associated lipodystrophy. Pasteurotide is used in Cushing disease. Yes, true. It's a true statement. You know, octreotide, we have pasteurotide nowadays. Nifedipine belongs to CCD. And CCDs are smooth muscle relaxants. They cause uterine relaxation, not stimulant. So here they have given nifedipine is a uterine stimulant used in PPH false. It is a relaxant. So it cannot be used in PPH. So the answer is D. And most of you have given that right. So just go through the option once again. Okay. So take a 5 minutes break. We'll be back. Just 5 minutes only this time. 5 minutes. Okay, so welcome back. Question number 66. An infertility case was referred to a specialist. The female has high prolactin levels. Which drug is used to manage this infertility case? Folotropin is FSH, lotropin is LH, but the problem is not decrease in FSH LH, it's prolactin. How to decrease prolactin? You have to stimulate D2. So the drug which can stimulate D2 is bromocriptine. So either we give bromocriptine or cabergoline to decrease prolactin levels in this lady. Haloperidol is not at all given because it's a D2 agonist. It's a D2 blocker and it increases prolactin levels and worsens the problem. So bromocriptine, cabergoline are D2 agonist which can be used to manage hyperprolactin because D2 agonism decreases prolactin, antagonism increases the prolactin. So the answer is C. Correct? Yes. Question number 67. Which of the following reduce the level of dihydrotestosterone and used in BPH to reduce prostate size? So you know that testosterone will become dihydrotestosterone which can cause BPH and the enzyme which does that is 5-alpha reductase. So if you want to manage BPH, you have to inhibit the enzyme 5-alpha reductase. So which drug inhibit that? The answer is finasteride. So finasteride inhibits 5-alpha reductase. Flutamide, it's an androgen blocker. It's an androgen receptor antagonist. And that is used for prostate cancer. Where do you use it? Prostate cancer. Sildenafil, all of you know. It's a phosphodiesterase 5 inhibitor. It is used for erectile dysfunction and pulmonary hypertension. Sapropterin is not so important for you. Please remember that. BPH. Remember the drugs for BPH. Two types of drugs we use. Alpha blockers, fast acting, and 5-alpha reductase inhibitors, they are slow acting. The alpha blockers which we use are prazosin and tamsulosin. So these are drugs for BPH. Question number 68. Which of the following drug is not used in erectile dysfunction? Tadalafil, yes, anything ending with fil is used in erectile dysfunction. Phentolamine is a vasodilator. You can inject into the penis. Alprostadil is a vasodilator which is used for erectile dysfunction. So A, B, D all are used. Thiazides, you all know it's a diuretic. It's not used for erectile dysfunction. But in fact, thiazide causes erectile dysfunction. So tell me, what drugs cause erectile dysfunctions? Drugs causing erectile dysfunction, particularly the antihypertensive drugs. They are thiazides, beta blocker, alpha blocker, clonidine. These drugs themselves can cause erectile dysfunction. So answer is C. Thiazides are not useful, but we can use phentolamine, alprostadil. One more drug is papaverine. These three drugs are injections available for erectile dysfunction. Pills are orally available drugs for erectile dysfunction. Okay. Question number 69. Which of the following is a drug of choice for hyperthyroidism in first trimester of pregnancy? The answer is option A, propyltyrosol. So we write it as PTU. Remember it as पहले trimester में use होता है. Then for second and third trimester, the drug of choice is carbimazole. Carbimazole also drug of choice for Graves' disease. Thalidomide has anything to do here. Thalidomide is teratogenic, we don't give it. Radioactive iodine we don't give in pregnant women because it's a radioactive material. So the answer is option A, propyl thiouracil. Okay. Moving on to question number 70. Which of the following is an aromatase inhibitor used in breast cancer? Option A, tamoxifen. It is a serum used in breast cancer. The answer is option B, letrozole, which is an aromatase inhibitor used in breast cancer. But letrozole is also used for one more condition, that is to induce ovulation in PCOD. Roloxifene is also a serum. It is used to manage postmenopausal osteoporosis. What is the difference between tamoxifen and roloxifene? Tamoxifen increases the risk of uterine cancer. That risk is not there with roloxifene. Fulvestrant is a SERD used for breast cancer. What is SERD for? Selective estrogen receptor downregulator. So the answer is aromatase inhibitor name is letrozole. Option B. Again your OBG question. Which of the following will you advise for a 23-year-old female coming to the clinic on 6th day of unprotected sexual intercourse and wants to avoid pregnancy? See, emergency contraception or post-coital pills, they are usually given within 72 hours. The options are you have mifepristone, you have combined OCP, and you have one more option, levonorgestrel. These are given up to 72 hours. But recently we have one more drug called ulipristal, which can given up to 120 hours, that is 5 days. That is 5 days. But this lady is coming after 5 days, that is 6th day. Then these 3 drugs won't help. So what is the best option is intrauterine contraceptive device. For this, IUCD will be the best option. Option D. Okay. Yes. Now certain psychiatric based pharma questions let us take up. Question number 72. Patient was on antidepressant drug. He consumed wine and presented to the hospital with palpitations and headache. His BP is high. Which one of the following antidepressant was given? See, taking wine, beer, cheese, then antidepressant being taken, the BP goes up. This is a cheese reaction. And the cheese reaction is done by MAO inhibitors. How do you bring down BP? You give antihypertensive like phentolamine. 2 MAO inhibitors, remember, they will ask you phenylazine, iproniazid. Fluoxetine is a SSRI. Imipramine is a tricyclic antidepressant. Venlafaxine is a SNRI. So what drug will cause cheese reaction is MAO inhibitors. 73. Which of the following antidepressant is a SNRI? Nortriptyline is TCA. Imipramine is a TCA. But the confusion is duloxetine, dapaxetine. Duloxetine, venlafaxine, milnacipran are SNRIs. Dapaxetine, fluoxetine, escitalopram, citalopram, they are all SSRI. So what is the question asking you? Identify the SNRI. The answer is duloxetine. Dapaxetine is used for managing a condition called, remember, DOP, P for given for premature ejaculation problem. So duloxetine is used to manage premature ejaculation. And duloxetine, apart from depression, it is used for managing a condition called stress urinary incontinence. Stress urinary incontinence, we use it. Duloxetine. Let's move to the question number 74. Which of the following is not an adverse effect of SSRI? Selective serotonin reuptake inhibitor. Does they cause insomnia? Yes. Do they cause anxiety? Yes. Diarrhea? Yes. But they don't cause premature ejaculation. So the answer is D. SSRI causes sexual dysfunction called anorgasmia and delayed ejaculation. Not premature, they cause delayed ejaculation. So SSRIs are fluoxetine, fluoxamine, sertraline, paroxetine, right? Naproxetine, citalopram, escitalopram. They can cause nausea, vomiting, diarrhea, insomnia, anxiety, sexual problem. Right? Yes. They can also ask you which antidepressant causes least sexual side effect. A bar E means adverse effect. The name is bupropion. Mirtazapine. They cause least sexual problem. Okay. Now let us find out which of the following statement is false about antidepressants. Imipramine is used in nocturnal neurosis. True. Imipramine also blocks muscarinic receptor, retains the urine, so given in nocturnal neurosis. Amitriptyline is used in diabetic neuropathy and migraine prophylaxis. True. Amitriptyline, apart from depression, given for neuropathy and migraine. Doxepin is used for pruritus. True. Remember doxepin, that is also TCA. These have histamine blocking properties, so can be used for pruritus. Then duloxetine is used in overactive bladder. Duloxetine is used in overactive bladder. That's a false statement. Duloxetine is used for stress urinary incontinence, not for overactive bladder. So option D is false. A very good question asked by Prathamesh. Sir, SSRI are used to manage anxiety. But their adverse effect itself is anxiety. How? Now please understand, whenever a person comes with acute anxiety, we don't give an SSRI because acute anxiety, this drug itself causes anxiety. Suppose patient is having chronic anxiety or general anxiety disorder, what we do? General anxiety disorder, we give SSRI with benzodiazepines. So we continue this for 3 months, and then after 3 months we stop this benzodiazepine and continue SSRIs. We continue SSRIs. Now this SSRIs cause anxiety initially only, after that they don't cause. So initial days they cause anxiety, so I need to stop anxiety by adding benzodiazepines. And after 3 months we stop benzodiazepine and continue SSRIs. This is what the psychiatrist will do. But question is, why don't you continue benzodiazepines only for anxiety, sir? Problem is benzodiazepines cause sedation. Suppose you have anxiety and you are sleeping. Suppose I give a sleeping tablet, that won't work out. And benzodiazepines, if you use for long period, they cause tolerance. The drug will not work. So it is better to do this method. Okay, I hope you got that point, Prathamesh. Let's move to question number 76. Which of the following statement is false about Antidepressant, same thing like that. SSRI are the first types of drugs in anxiety, chronic anxiety, OCD, PTSD, phobia. Yes, nowadays they are the first choice. Bupropion is used for smoking cessation, true. Duloxetine is used for premature. I told you P for premature, true. SSRI is started alone in a patient with depressive episode of bipolar disorder. That's a false one. Now, what is bipolar disorder? This is a normal mood. So let us imagine this is the normal mood. This is mania and this is depression. That is called bipolar disorder. Now suppose a person comes to your hospital with bipolar disorder and he is having only depression. What happens? You give SSRI. SSRI will treat only depression. What happens if you give only SSRI? The person will become maniac. So whenever a patient comes with bipolar disorder, you have to treat both mania and depression both. So you cannot give SSRIs alone to manage depression in bipolar disorder. That's why the best drug for bipolar disorder is lithium, because lithium can manage mania also, it can manage depression also. That's why it is called mood stabilizer. One more drug which has the same property is valproate, which can also be used to manage mania as well as depression. That is also mood stabilizer. Right. Moving on to question number 77. A psychotic patient is put on haloperidol. What is haloperidol? It's a D2 blocker, meaning typical antipsychotic. He developed torticollis after 6 hours of starting drug. Which of the following drugs are used in the management of torticollis in this patient? So whenever you give a typical antipsychotic, dopamine is blocked, so acetylcholine goes up, and that will lead to a problem called acute dystonia. And that presents as torticollis or the ocular crisis. What is the treatment? The treatment is to decrease acetylcholine, and they are called anticholinergics. So what drug I can give? The drug what I can give is promethazine. If promethazine is not there, the best option will be benzoxazole. So this is what I can do. Again, when we give this antipsychotic drug to elderly people, they develop drug-induced Parkinson's disease. That time also the drugs we use is promethazine or benzoxazole. Whatever I am telling you, these typical antipsychotics, they cause extrapyramidal symptoms which is repeatedly tested. The first one is acute dystonia. I told you how to manage it. Suppose I give it to elderly, they develop drug-induced Parkinson's disease, same treatment. Third problem, what they develop is akathisia, inability to sit at one place. How do you treat that? We use a beta blocker called propranolol, or we sedate a person with benzodiazepines. Fourth problem is neuroleptic malignant syndrome. Here the body temperature goes up, muscle rigidity, myoglobinemia will happen. The treatment for that is dantrolene sodium. It blocks ryanodine receptor 1. And the ion responsible for this is calcium ion, neuroleptic malignant syndrome. Fifth problem that happens is tardive dyskinesia. For that we use VMAT2 inhibitors and they end with benazins. So this is an extrapyramidal symptom which is frequently tested in exams, never miss from psychiatry. First is acute dystonia in young people, drug-induced Parkinson's disease in old people, after some months akathisia, after some months neuroleptic malignant syndrome, high body temperature, and after some years start dyskinesia. These are called extrapyramidal symptoms seen with typical antipsychotics because they block dopamine. Moving on to question number 78. A patient of schizophrenia was on olanzapine. What is olanzapine? Anything ending with apine, they are atypical antipsychotics. meaning they block 5-HT2 more than D2. Since few months it was effective in controlling the psychotic symptoms, but patients stopped taking the drug. What may be the most likely reason? This olanzapine and one more brother of that is clozapine. Both of them have one problem. Atypical antipsychotics, they cause metabolic syndrome, that is weight gain. The reason why the patient would have stopped is because of weight gain. Tardive kinase is not because of them, it's due to typical antipsychotics. Agranulocytosis is not by olanzapine, it is by clozapine. Dystonia is by typical antipsychotics, not by this. So since we are discussing this, let me tell you in detail the adverse effect of clozapine. Clozapine causes agranulocytosis. It's a rare adverse effect. Apart from that, it can cause cyalloria, which is called wet pillow syndrome. It can also cause myocarditis, but when you give it high dose, it can lead to seizures. That's the adverse effect of clozapine. So please remember. Question number 79. Which of the following statements are false? Clozapine and lithium have anti-suicidal property. True. Very much true. Aripiprazole and ziprasidone. Remember, aripiprazole and ziprasidone are atypical. They cause least weight gain. True. That's why most of the psychiatrists write aripiprazole and ziprasidone, because least weight gain, least cognitive problems. But one complication with ziprasidone is QT prolongation. One specialty you have to remember about aripiprazole, it's also a partial D2 agonist. That's true. Z-track technique is used while giving antipsychotics IM. True. Sometimes when we give antipsychotics, we give them by injections and we use a technique called Z-track. Lurasidone causes maximum external symptom. False. Lurasidone, risperidone, they all belong to atypical antipsychotics. They don't cause extrapyramidal symptom much. But if you give high dose, they may cause, but normally they don't cause extrapyramidal symptoms. So that is also a false statement. So the answer is option D. Moving on to question number 80. Which of the following is avoided in a pregnant woman with mania? Valproate, lithium, carbamazepine, olanzapine. Avoided, they are asking. Now please understand, valproate is teratogenic, lithium is teratogenic, carbamazepine is also teratogenic. So in that, you have three enemies. In that, who is best enemy? O is worst enemy. So the worst which we should avoid is valproate, because the risk of teratogenicity is more with valproate. So if I want to avoid, I have four options, I will avoid valproate. Suppose I change the question, which one will you choose among four? I will go for antipsychotic like olanzapine. That is safer. What is the problem with valproate? It causes neural tube defects. What is the problem with lithium? It can cause Epstein's anomaly. It's a cardiac defect. Okay, so this is the reason. The last question is this. Which of the following is not an adverse effect of lithium? Is it teratogenic? Yes. Does it cause SADH? No. It causes diabetes insipidus, and the treatment for that is amiloride. So it doesn't cause SADH, it causes diabetes insipidus. Now it can cause fine tremors if the dose is fine. But if the dose is not fine, then it causes coarse tremors. So in the exam, if they give coarse tremors, that means the dose is high. Toxicity. So what are the normal levels of lithium? It's 0.5 to 1.5 milliequivalent per liter. More than 1.5 milliequivalent per liter, this is going to cause toxicity of lithium. And how do you manage toxicity of lithium? By doing dialysis. Dialysis should be done. And remember, the drug requires therapeutic drug monitoring. That means you have to check the levels of lithium. When you check the blood, when you check the lithium levels, when you draw the blood should be drawn 10 to 12 hours post dose. Meaning, suppose I take the tablet at 9 o'clock in the night, morning 9 you can draw the blood. That's the meaning. Yes, does it cause hypothyroidism? Yes. What's the treatment for hypothyroidism? Should I stop the lithium? No. Treatment is levothyroxine. You give levothyroxine and treat it. So this is about the adverse effect of lithium. It's teratogenic. It can cause fine tremors, hypothyroidism, diabetes insipidus, and lithium can also increase the count of leukocytes. And it's the drug of choice for bipolar disorder prophylaxis, since it's a mood stabilizer. Again, the question is drug of choice for rapid cyclists. It is valproate. Suppose a person comes with acute mania. Then what to do? Give antipsychotics plus lithium. Why not lithium? Lithium will not work immediately. Lithium takes time. Lithium takes time. So give antipsychotics which act immediately and bring down the mania. If both antipsychotics are not there, lithium is not there, then you can give valproate in acute mania conditions. Acute mania condition, you can give valproates. Okay, this is about the different drugs. Particularly lithium is being tested a lot. So with that, we are winding up our T&D session. I hope you got most of the questions correct. I hope you got the revisions with me. And any other doubt, I am there to take up for another 10 minutes. So any doubt you can ask me here. Yes, thank you, Abhijit Singh, for answering very well. Keep up the same Josh. Yes, Prathamesh, thank you. Okay, no doubt. That means all the best for your exams. Go with the confidence. I am again telling you, if you believe in yourself, anything is possible. So first thing in any exam is self-confidence. You believe on yourself and you will 100% excel. So with that, all the best for exams. Meet you soon and waiting for your messages. Thank you all.